Hi, this video was done for SK Meniscus certificate course purposes. I would like to share a case of a 15-year-old boy who was treated in my department. He had an injury 3.5 months prior to surgery. Initial diagnosis was medial meniscus, posterior cruciate ligament and medial collateral injury. According to parents, all with the possibility to heal. We have done simultaneously a single bundle PCL reconstruction with quadruple hamstrings and medial meniscus posterior root repair. Initial diagnostics after trauma was normal X-ray and findings on MRI. This is how cruciate ligaments and meniscus looked on the frontal plane. This is sagittal sequences. ACL injured PCL. Here we can see the fracture of the tibial epiphysis. It wasn't seen on the initial X-ray. Here this is how it looks on the meniscus. We could see injury on the posterior root. After 3 months, the parents made second MRI. We can see that the PCL look still injured. The ACL is normal, the PCL is injured. We can see the injury on the posterior root and extrusion of the medial meniscus. Normal ACL, injured PCL with the remnant, medial meniscus and extrusion. On the talus we can see severe posterior instability, but it's reducible on the right side. So we made an arthroscopy, posterior medial root repair with 2 tunnels drilled with 2.4 mm cannulated drill from Arthrex. We used a Scorpion device, 2 suture tapes and a button. We performed single bundle PCL reconstruction with 4-stranded semitendinosus and gracilis. Graft diameter was 9 mm. Femoral fixation was Arthrex tightrope RT button, and the tibial fixation with tightrope and concave ABS button. MCL was stable and it was tested before anesthesia. This video is speeded because of the time purposes. Extrusion of the medial meniscus, bulky ACL, there is a root injury. The quality of the remnants is not sufficient. You could see it also on the talus. So we debrided the footprint to the bleedy bone. Then I performed posterior medial portal, put the cannula, the bride also from this portal. Also performing PCL reconstruction without root repair would be much technically difficult. Here I drilled the first tunnel. Then I use Scorpion device and put the first tape. The meniscus is reducible. Then the second tape. I drilled the second tunnel here, put the tapes into the tunnels, pre-tension, not the final tension, but it's reduced, and then I debride the tibial side of the PCL insertion. Try to make a space. This is the view from the posterior medial. Here we can see root. Then I put the special guide for PCL. After the tunnel, after the wire placement, I check it on the fluoroscopy. If the position is correct, then I drill the tunnel. I protect the wire with the spoon. Then I drill the femoral tunnel. I also use the drill as a guide for the wire, where I can see the diameter of the graft to not harm the cartilage, but to be close to its surface. I drill about 25-27 millimeters to have a space for tensioning after with the tightrope button. Then I put the graft, which you could see before. The graft is inserted. Sometimes it's difficult. We have to be aware of killer turns, so I help to pass it from two sides, from anteromedial portal and posterior medial portal, to make a smoother pass. Here we can see PCL graft with nice tension. The small pieces of bone will be flushed out after the procedure, but we can see that the extrusion is reduced. We can check the stability after the tension with the tight rope.